Hi, everyone. Thank you for joining us today. My name is Matt Kuntz, and I'm the Executive Director for NAMI Montana. And we are delighted to bring you another episode in our webinar series, which is sponsored by the Montana Behavioral Health Division, which I'm getting used to saying that. So brand new name, but these are always special, but I'm really excited for today.
All right, everyone, thanks so much for joining me. If you could just let me know if you're able to see my screen and you're able to hear me okay, can you give me a thumbs up sign so I know we're good to go? Okay, I see at least from Colleen, so okay. Well, thank you everyone for joining me, whether it's through the live webinar or for those of you that are able to catch this through the recording. It's wonderful to have you. I want to thank Matt so much for giving me this presentation, or the opportunity to give this presentation. It's a topic that I've spoken on in other meetings and in other parts of the country, but it means so much for me to be able to share this with a Montana audience. Because this is the state I love, this is the state that I practice in, and this is a state that we well know desperately needs more options and more effective treatments when it comes to things like depression, PTSD, and certainly suicide. So here are some of the things that I'm hoping to talk to you about today. I'm going to be talking about some innovative treatments, including things like TMS, ketamine, a ketamine derivative called S Ketamine. And I also want to make mention of what's happening in the field of psychedelic medicine or psychedelic psychiatry, and then also how the concept of integrative psychiatry works into this model of not only treating mental illness, but trying to get people to a point of optimal mental wellness, because I really feel passionately that that's the goal that we should be setting for ourselves. So just a little bit about me. I am a Montana girl. I grew up in Billings and left Billings, though, to do a lot of my education and training. So I did undergraduate in Utah, I did med school in Nevada, and then I went on to do my psychiatry residency and fellowship in New York. And I'm double board certified in general psychiatry as well as child and adolescent. And I returned to Billings in 2013 to start practicing. And I'm currently the owner and medical director of Montana Psychiatry and Brain Health Center. I also founded what's called the Mood Restoration Institute. And it really is, I feel it's my personal mission and my passion to help people find innovative approaches to treating mental illness, but also to help people find solutions beyond just the prescription pad, because that's so often where we go when we think about treating mental illness, is we think about medications and prescriptions, but we really need to widen our view of how we approach these challenging mental health disorders in order to help people achieve not only freedom from mental illness, but optimize their mental wellness. But in addition to all the psychiatry stuff, I'm a mom of 6. There are a lot of things I love outside of the office, one of them being spending time at a cabin near the Boulder River, south of Big Timber. That is a big part of me maintaining my mental health. So a word about my practice. It was founded in 2009 with 2 other psychiatrists, and our clinicians currently include, we have a pretty big group at this point. We have myself and another psychiatrist, as well as 4 psychiatric physician assistants, a psychiatric nurse practitioner, and 3 therapists. And we provide multiple services, including general psychiatric care, but also psychotherapy, TMS, which is Transcranial Magnetic Stimulation, ketamine and S Ketamine. We just recently started a group metabolic health program that I'm very excited about. And then we also provide some services for YBGR here in town in Billings. So I want to say a word, though, about my personal journey for looking for new and effective treatments. And for many of those in my field or in medicine, where we start looking outside the box, or we start venturing into that territory of experimenting or trying things that are not widely used yet, but are kind of on the frontier. A lot of it comes from a journey of personal loss or personal challenge, whether that's that we have our own health crises or there's something happening in our families or something with a patient. And in my case, it was the loss of my first patient to suicide several years ago. And that corresponded very closely with just within a few weeks of when the world lost Robin Williams, such a brilliant man, comedian, actor, and someone I had loved growing up with his various movies. And so those two losses were very, very difficult for me on a professional and personal level, and just really made me think of, what am I doing in my profession? Is there more that I can be doing? And that's what really set me on the path of looking at, first of all, TMS. Ketamine closely followed that. And it's been an amazing journey since then. I see so many incredible results, and that's why I'm so passionate about doing these kinds of presentations, because we have these amazing tools at our disposal that have become more mainstream, but they're grossly underutilized. And so I want people to be more aware so that they can get the treatment that they need. So let's ask the question, just getting back to basics, why do we even have a need for new treatments? And first of all, let's just look at some of the things involved in really the high cost of depression. So at this point, there are over 300 million people suffering from depression worldwide, and it's the #1 cause of disability worldwide. That's a pretty devastating thing. And by 2030, we're expecting it to be the leading cause of global burden of disease. I wouldn't be surprised if that timeline is now accelerated because of the impact of the pandemic. What we're seeing is that the prevalence of major depression has tripled during the pandemic. That is especially true of our child and adolescent population, where the mental health crisis has reached the level of a national emergency. And when we talk about the high cost of depression, yes, there's the cost of the medical services, but there's a lot of lost work and absenteeism. This has an impact on relationships and on families. So it's very difficult to put a dollar sign on the true cost of what depression does to a person's life and all of those who love them. And then there's the challenge of just the lack of response to medications and talk therapy. We know that about 1/3 of patients with major depressive disorder end up falling in the category of what we call treatment resistant. I like to call it treatment refractory. I don't like that word resistant, because I feel like in some ways it implies that the patients are broken or they've done something wrong. But treatment refractory depression, so what that really means is that people have had an adequate medication trial of at least one medicine where it's been adequate dose, an adequate amount of time that has been tried, and they have not adequately responded. And there was a trial done years ago called the STAR-D trial, and I encourage you to look that up for more information. But what it basically illustrated was that if someone has one medication failure and they go on to try another medication, the likelihood that each successive medication trial is going to bring them to a point of response or remission, that starts to decline the more medication trials and failures that you have. And at the same time, the side effects that people experience tend to go up as well. So that is really a challenge. And another thing is, there haven't been many revolutionary new mechanisms of antidepressant treatment in the past 30 years. Most of the antidepressants we have are some sort of variation on those medications having an impact on serotonin levels or receptors, or maybe it's norepinephrine or dopamine, but not a lot that's new outside of that. And then again, just coming back to how some patients suffer from side effects that impact either their quality of life or just make the medication so intolerable that they cannot stay on them. So we really need more treatments with better efficacy. So here's just an illustration of the STAR-D trial and what I was saying about the chance of response declining with more medication trials. And the other part of this is that patients want more options. I hear this all the time. People are tired of feeling like they're kind of on that hamster wheel of trying medication after medication and things not working. So I think we have to be mindful of what other treatments are out there that maybe don't have the same side effect burden. We have to consider special populations like the elderly or women who are pregnant or breastfeeding, where medication may not be the best fit. Some people have some strong feelings about taking a daily medication versus maybe having a treatment option of something that could be used more on a periodic basis. And then also, we really have a need for treatment that may have a more rapid response time. With medication, it can take sometimes weeks, sometimes months after doing dose adjustments to see a level of response. And when you're dealing with someone who's severely depressed or even suicidal, that sort of a time frame is not ideal. And it's not just patients who want more options, it's clinicians too. It's very challenging when you're working with someone where you feel like you've tried all the tools that you have in your toolbox with the best you have to offer with psychopharmacology, but you feel like you're still not able to get them to a point of feeling better. So it's wonderful as a clinician to find out that there are other tools that you can utilize. And we know too, just the escalating suicide rates. And there you see our wonderful state of Montana in the dark blue in that very high percentage category of our suicide rate. And just to reiterate, now with the pandemic, we're seeing escalating rates of suicide, especially in our younger population. So we need more effective treatment. So that takes me first to telling you more about TMS. It's a mouthful, Transcranial Magnetic Stimulation. But I want to start first with giving you a brief history of brain stimulation. And I'm kind of a history nerd. I really love learning about the history of medicine, which I find to be fascinating. And sometimes it's a little morbid too. But the history of brain stimulation takes us back even to looking at ancient Greece and ancient Rome with physicians like Galen or Hippocrates, who wrote about how they were using the torpedo fish, which was an electric ray fish. They were using the torpedo fish to treat conditions like headaches or gout. And they would have the patients stand on the torpedo fish if they had gout, or they would apply the fish to the forehead or the head if people were suffering from headaches. And I believe this is some of our earliest known use of electricity, electrical stimulation for treatment of medical conditions. And then fast forward to 1791 with Luigi Galvani. He was doing experiments with early batteries showing electricity flowing through nerves. And what he did was he activated an exposed nerve with electricity to produce a muscle contraction. And then he was also working, his nephew, Aldini, was working with him and was conducting experiments at the base of the guillotine during the French Revolution to also show how electrical stimulation would produce muscle contractions. Now, fast forward again, 1974, over across the pond in England, we have Tony Barker, who showed that he could stimulate a peripheral nerve with a magnetic field. And then years later, he ushered in what we now know as modern TMS, when he demonstrated the first magnetic stimulation of the human brain, the human cortex. So here's a little illustration just of the timeline, really more modern times, not going clear back to ancient Rome and ancient Greece. But we have come a long way just in a very short period of time. One of the first options that we had for electrical stimulation of the brain was ECT, which was approved by the FDA in the late 1970s, even though it had been around really since the 30s. It was approved in 1979. Then we have Tony Barker. Then we have a gentleman named Mark George in South Carolina, who in 1995 demonstrated an antidepressant effect associated with TMS, with the stimulation of the brain. And then years later, we have different coils that are being developed that treat different areas of the brain in different ways. And I'll tell you a little more about that in detail. And there is something thrown on the timeline here too in 2005 about VNS, which is vagal nerve stimulation therapy. It's not commonly used, and a lot of people don't know much about it, but it was approved for treatment of depression by the FDA in 2005. So this is an illustration of all of the FDA approved devices now for TMS. When the field first started in 2008, there was just one. There was one called the NeuroStar device. That was followed by the BrainsWay device, which is what I used for the first 5 years of doing TMS. And now we have 7, which is amazing because we have more options in terms of different coils and different, just different options that we have to offer patients. So we really see the field accelerating and maturing, and it's great to see more options here. So I was talking about coils and how coils are used to stimulate different areas of the brain. So one of the most common coils that's used in the treatment of depression is what's called the figure-8 coil. So kind of the coil itself, kind of shaped like this, housed in that kind of black plastic form that you see there. And what you see on the right, the slide on the right, shows you that the shape of the coil really determines the level of intensity or the level or the area that ends up being stimulated. And so you can see where it illustrates the figure-8 coil, that it's where those two coils come together in the center that you get the highest peak of stimulation and intensity. And then another option for the treatment of depression is what's called the H1 coil. This is manufactured by Brainsway, and you can see on the right how different that looks from the figure-8 coil. You have many different overlapping coils in different dimensions and fields. The Brainsway device is more of a helmet that's placed on the patient with the coil inside, versus the figure-8 being more of that, like the black plastic covering the coil that you saw in the previous frame. So how does TMS work? And this is a complicated question, and I don't want to go down the road of getting too technical, but TMS works by using MRI strength magnetic pulses over an area of the brain. Most commonly, it's over an area called the left dorsolateral prefrontal cortex. Again, that's a mouthful, but that is a very common site for the treatment of depression. And it works by the magnetic coil induces electrical activity and stimulation within the brain. So even though we're treating on the surface of the scalp, that magnetic stimulation is able to penetrate through the scalp into the brain. It induces electrical stimulation, and that then stimulates other areas of the brain that are deeper or wider than just that area of where we're stimulating with the coil. And on the bottom there, you can see just some different ideas of how TMS may be working. So just like I was talking about medications being different variations maybe on how they affect serotonin, TMS may affect serotonin too. Also, there's a lot of talk now, not just about neurochemistry and brain chemicals, but also about brain connectivity, how different areas of the brain are connected. And so again, with TMS stimulating one area of the brain, it helps to kind of activate various brain networks. And then another way that TMS seems to work is that it increases what's called BDNF, brain-derived neurotrophic factor, or like we sometimes like to call it, miracle grow for the brain. It really does help to develop new brain activity, even to repair neurons that may be damaged. So anything that increases BDNF is a good thing. And this isn't unique just to TMS. This is something I'll mention too with ketamine, but even things like exercise can help increase BDNF. So there are a lot of things we can do even in our daily activity that may help to stimulate better brain health. And just some general information, the FDA approved or cleared TMS in 2008 for the treatment of major depressive disorder. And the trials that were done originally were for one failed antidepressant. The reality though, the real world application, because real world, we talk about what insurance requires for accessing these treatments. Typically, insurance requires at least 1 to 4 adequate antidepressant trials. Most lean more towards 4. It's been 4 for many years. In the last couple of years, we've seen a softening of that to where sometimes we'll see an insurance that only requires 2 antidepressant trials. Now with Medicare, they're saying it has to be a single antidepressant trial. So I'm very excited about that because I don't think we should be making people wait this long to get TMS. I don't think we should be running people through this many medication failures. So there is some progress being made in that regard. Sometimes insurance requires more than one antidepressant class. So like if someone has been on SSRIs like Prozac or Zoloft or Lexapro, they may also want to see that they've tried something like Wellbutrin or that they've tried Effexor. So not just one antidepressant class. And then most insurance plans do want to see that there's been a trial of some sort of evidence-based therapy. Very commonly CBT is what they will specify that they want to see. So major depressive disorder has been the condition that's been treated the longest and most commonly with TMS. But some of the newer FDA approvals that have come out within the last 1 to 3 years have been approvals for OCD and even for smoking cessation. The challenge is that I have not seen very consistent coverage of OCD or smoking cessation so far, but hopefully with time that may change. Some unique features and advantages of TMS, and I think this is very important to know because a lot of people are very reluctant to consider TMS because they equate it with ECT, and there are some really important distinctions. So TMS is non-invasive and it's an office-based procedure. So there's no anesthesia required. Patients are awake and alert, and there's no recovery room or downtime that's needed. So often people are coming over their lunch hour, or we try to schedule them before or after work or school, and they're able to drive themselves to and from, and they're able to return to their daily activities. And flexible targeting of treatment is possible. This depends on the device that you have, but depending on the coil and the device you have, you can treat a lot of different areas of the brain. Like I said, the left dorsolateral prefrontal cortex is the most common area for treatment of depression. But when you get into treating different areas of the brain, there are some other potential psychiatric or neurologic conditions that may be targeted with, depending on where you place the coil. But there are no cognitive side effects with TMS. And this is a distinction from ECT, where you can see memory loss or a cognitive impact from ECT. And TMS is generally very well tolerated. It's sometimes uncomfortable in the first few days while people are getting used to that type of stimulation, but that tends to go away. Often people are tolerating TMS better than they've tolerated medications. And it is a focal treatment, meaning that it's more of a pinpointed specific location that's being treated versus when you are taking a medication, when you ingest that medication, it has effects throughout the body. And sometimes that is what leads to the side effects. Or even with ECT, the impacts of ECT are affecting much more than just the very focal area that's being targeted with TMS. And patients, for the most part, they really tolerate it, they like it, and many people are very, very happy with the results. And I just want to illustrate another coil here. This is what we jokingly sometimes call the Princess Leia buns coil. This is the one for OCD, so you can see how different that looks from the H1 or even the figure 8. And for OCD, the treatment location is really kind of right down the center, versus depression being more of a left-sided treatment. And then on the right, this is a slide illustrating a new FDA approval for something that's called theta burst or intermittent theta burst treatment. And essentially what that is it's a condensed pulse of TMS to where instead of it being more of like a 20-minute treatment cycle, or with the older systems, it used to be a 37-minute treatment cycle. Now we're able to condense a TMS session into more like 3 to 5 minutes, which is really pretty amazing. And this is just an illustration of one of the studies that came out years ago. This is with the BrainsWave device and deep TMS, but the results they showed are very typical of what has been shown with other TMS research. And that's that about 75% of patients experience at least response, meaning a reduction of at least 50% in their rating scale. So in this study, they used the Hamilton Depression Rating Scale. In the office and in the TMS field, the PHQ-9 is commonly used. So a 50% reduction, which is substantial, even for a lot of patients who have suffered for years from depression. Even a 30% improvement in depression gives them a lot of relief from their condition and helps them to be more functional. But what's exciting about this too is there was a very high percentage of people who even showed remission from their depression, meaning that their depression largely diminished, their symptoms largely diminished. So and so that shows that there are still about 25% of people who don't respond to TMS. This is not a cure-all for everyone across the board. There's still that segment that doesn't seem to respond. But there were follow-up studies done that showed when they continued to treat people, because you see it says 20 or 30 sessions, but in these studies, they continued to treat people for more sessions, and many of those who had been non-responders at 30 sessions went on to respond later on. So this is another challenge with insurance, because insurance typically doesn't approve more than 36 treatments. But I'm hoping that's something that with more research and more advocacy in our field, that we will see insurance open up to covering more if that's what people need. Some important safety considerations and side effects. One of the main risks associated with TMS is the risk of seizure. Now, it is a small risk and equivalent to the risk associated with many of the antidepressants that people have been on by the time they come to see us. So when we're doing an intake, we do screen for a history of seizure disorder. It doesn't always mean that they cannot do TMS, but it just means we need to take some extra precautions and may need to alter their protocol. Another contraindication is if someone has metal clips or stents or implants in the head, like if someone has a cochlear implant, we need to know about a vagal nerve stimulator or pacemakers, things like that. We're usually able to still work with people who have pacemakers or VNS, but if they have metal clips or stents within the head that would also prevent them from being able to get an MRI, those would be situations where we cannot do TMS. Another caution is where people have scalp tattoos, because sometimes the tattoo ink contains metallic ingredients, and that would be potentially dangerous with the TMS. Some other safety considerations, people are cautioned not to drink any alcohol when they go through the course of TMS treatment, because alcohol can increase the potential risk of having a seizure. We also monitor people for changes in sleep, changes in medications, but because that might alter our treatment approach. And we also have everyone wear ear protection. It's not a very loud treatment, but that is a recommendation from the device manufacturer. The most common side effect we see with TMS are headaches, but those are usually within just the first few days or the first week of treatment. The headaches are usually alleviated with just over-the-counter pain relievers like Tylenol or ibuprofen. And we treat a lot of headache and migraine sufferers, and it's been pretty rare where the headaches have made it to where people have to stop TMS. What we have seen is in some cases, migraine sufferers tell us that they aren't getting migraines like they used to, or sometimes they even come into treatment with a migraine and they notice that it's gone by the time they're done with their treatment. So it can kind of go either way as far as whether it seems to help the migraines or whether it tends to aggravate it. But most people do really well and get over the headaches in a few days. So what to expect with a TMS treatment? The sessions can vary in length, anywhere from 3 to 37 minutes. I think it's pretty rare that anyone across the country is doing 37 minutes anymore. I would say it's most common that people are doing a treatment that's closer to 20 minutes. But again, with the intermittent theta burst coming in, some of those treatment sessions are now being condensed to 5 minutes. The treatments are typically 5 days per week for 6 weeks. So that's 30 treatments to begin with. And then we do a taper over the remaining 3 weeks. Sometimes we do condense the taper if we have patients who come to us who are from out of town and maybe they're staying in an apartment or Airbnb during the time they're doing TMS or they're commuting. We'll try to condense the last 3 weeks if we're able to. But what's common, it's common to see a later response rather than earlier. So I caution people in the beginning not to expect to have a treatment and immediately feel better. It usually takes a few weeks to start noticing the effects. Some people are even later responders where we get to the end or the last week, and that's where they're finally seeing response. So it can be really variable. But usually what I see is an improvement in people's functioning before they report that their mood is necessarily better. So by that, I mean, I often hear from people that they feel like they're tolerating stress better, that they're leaving the house more, that they have been more productive, that they've increased their activity level. And another big thing that we often see early on is a reduction in suicidal thoughts, which are really commonly present in the people that we treat. So again, this is just kind of illustrating those differences between ECT and TMS, which I really went over. So a word on TMS coverage. TMS has coverage in every state for major depressive disorder, but still limited for OCD. It's covered by all major private insurance companies. With that being said, though, they often have variations in what they require. So we, after doing this for over 5 years, we're pretty good at reading those policies and knowing what we need to give them on the front end to be successful with the prior authorization process. Up until last year, there was really no coverage by even Medicaid across the country, but that is starting to soften, and Montana Medicaid started covering this last year, and that has been so amazing to open this up to so many more people in Montana who need this treatment. We've treated a lot of patients with Medicaid as their insurance. We're seeing great results, so we're hoping to give that information and that data to Medicaid to say, please continue to keep covering this vital treatment. And it is a pretty rigorous prior authorization process for most insurances, but the things that help move that along are if we're able to obtain medical records that show previous medication trials, getting printouts from the pharmacy that show what medications people have been on over the last few years really helps. And so we really try to prepare all of that on the front end so we're successful when we go to the insurance company and advocate for our patients. So some big TMS takeaways I want you to have are start thinking about TMS early in the course of treating major depression. I know we usually start with medications, but if you yourself are seeing that after one treatment or two medications that you're still not getting better, that's an important time to start learning about and thinking about TMS, and then seeking out a referral, or if you're treating patients or clients, try to help connect them with a referral to a TMS facility so they can get that treatment rather than going down that road of many medications that aren't working. And the future of brain stimulation, it's exciting. This is a young field. It was only 2008 that TMS was approved, but we're already seeing such an acceleration in new technologies and new treatment protocols. So we're going to see more of that over the years. And I'm hoping that in time, we'll see more indications for things like bipolar depression, because right now that isn't covered by insurance and it isn't FDA approved. But those are patients who also desperately need better treatments, and things like PTSD, autism, ADHD even, and the future is now. It's exciting because the research just continues to accelerate. So that brings me now to talking about ketamine, which is another breakthrough treatment for depression and several other mental health conditions. So just a little history about ketamine. This is not a new medication or drug. It's been around since the early 60s. It was approved by the FDA in 1970 for being used as a surgical anesthetic. And a lot of our early exposure and use to ketamine came during the Vietnam War, when it was even referred to as the buddy drug, because people could administer it in the field. A fellow soldier could administer it in the field while waiting for medical personnel to attend to the person who was needing help. And the reason for that was because ketamine has such a good safety profile compared to some of the other pain agents or surgical anesthetics that were in use at that time. But it's on the WHO, the World Health Organization's list of essential medicines. It's been there since 1985. It's used in a lot of different ways. It's used as a surgical anesthetic, but it's used in dental procedures, oral surgery, pediatric dentistry. EMTs use it out in the field for patients who are agitated. It's used in the ER if they need to rapidly sedate someone to treat certain conditions. So it has a lot of different applications, and there are off-label treatments in use for chronic pain. But the antidepressant effects had been noticed over the decades and years that it was being used for these other reasons. But it was really about 25 years ago where researchers started formally looking at how ketamine may treat depression or other mental health conditions. And there was a landmark study in 2006 that reported antidepressant effects even with a single IV dose. In terms of ketamine safety, it is still considered an off-label treatment of psychiatric disorders, even though we know there's a lot of research at this point to support that there are pretty clear antidepressant effects. It's still considered off-label. And while it's used most commonly in patients over the age of 18, it can be used for adolescents. And I have treated several adolescents successfully and safely with IV ketamine. And there are different routes of administration. IV is a common one, but it can also be given intranasally. It can be used given as an intramuscular injection. It can be even used orally as a compounded lozenge or a troche. And but there are some psychiatric cautions and contraindications, and that's why it's so important to have a mental health professional involved in whatever ketamine team there is, because there are a lot of ketamine pop-up clinics coming up, and ketamine is not just being used psychiatrists, it's being administered by doctors who are maybe anesthesiologists or emergency room doctors. But it's really important to have involvement of psychiatric professionals on the team, because certain conditions like borderline personality disorder or unresolved trauma, recognizing psychotic disorders or bipolar disorder where there may be mania present. These are conditions to be very cautious about, and in some cases, not to move forward with treatment. And there can be some medical cautions and contraindications too. It's a normal effect of ketamine to raise blood pressure during the treatment. And so for people who have a history of high blood pressure, you want to make sure that that blood pressure is well controlled before doing a treatment. Also, if someone has a history of bleeding within the brain, intracranial hemorrhage, if they have some other cardiovascular issues, that may be a reason not to proceed or to just proceed very cautiously with ketamine. And it is not recommended for use in pregnancy. Ketamine and addiction. So ketamine is abused in high doses as a club drug known as special K. There are other street names for it too. And it's actually a popular drug of abuse. It's the #1 drug of abuse in some Southeast Asian countries. Also in England, there have been pockets of high ketamine abuse. And it's a Schedule III drug in the US. So there are tight regulations around how the medication is to be administered and stored. And there is a condition called ulcerative cystitis that's found in daily abusers or just people who abuse high dose ketamine. It's called K bladder. So there can be some serious consequences with its use. But there have been studies showing that there can be benefit in substance use disorders under very controlled and monitored treatment approaches using ketamine. So we don't want to throw it out as a possibility if someone has a history of substance use disorder, but we need to be very mindful about the potential for abuse and misuse. I won't go too deeply into the different ketamine mechanisms of action, other than to say it's very different than our traditional antidepressants. One of the things that it tends to work on is a neurotransmitter called glutamate, which a lot of people have never really heard of within the field of mental health, but it also increases BDNF. And one thing it does is it helps reduce the activity of something called the default mode network. And there's a lot more talk about the default mode network happening also just in the broader field of psychedelic medicine and psychiatry. There's a great book out called How to Change Your Mind by an author named Michael Pollan, Pollan, that came out a couple of years ago. And he talks about the role of the default mode network with this treatment. And we also think in some cases, ketamine may be decreasing inflammation in the brain, neuroinflammation, that may be contributing to some of the psychiatric symptoms people are having. This is a slide that I love. A picture is worth 1,000 words, I think. So this was a picture that was taken of, at the top, this is a neuron that has been exposed, I think, to chronic stress or damage. And then the picture you see on the bottom is after ketamine, how you can actually see sprouting of the dendrites on the neuron, meaning there's some restoration and some new growth happening. And one of the early studies that was done was on stressed mice, because usually the studies are first done on animal models. But in this, they gave ketamine to mice and then exposed them to stressors that were supposed to be kind of equivalent to stressors that humans would have. So, and usually stress in the mice would lead to things like freezing or social withdrawal or not moving when they put them into the forced swim test, which is where they put them in water and they make them swim, which they tried to say is kind of like the equivalent of types of behaviors you might see in humans with PTSD or depression. But the ketamine mice didn't act depressed after stress, even just after one dose. So some of these studies are really fascinating. And then this is some of the studies have come from looking at veterans and their experience with injuries on the battlefield. And in this particular study, they looked at US soldiers who had been injured in Iraq that were treated with various anesthetics, including ketamine. And the surgeons were worried that ketamine might increase the risk of hallucinations or some sort of negative effects, and that might make their trauma worse. But in reality, the opposite happened. And what they found was that the people who had been treated for burns with ketamine actually had lower rates of PTSD, and that soldiers treated with ketamine on the battlefield had PTSD about half as often, even when they had severe burns and longer hospital stays. So here's what to expect with IV ketamine. I'm just going to address IV, not going into a lot of the other routes of administration, but we have patients fast prior to treatments. And part of that is because nausea is one of the most common side effects that we see with this treatment. So the fasting often helps reduce the feelings of nausea that can come up. We give what are called sub-anesthetic doses. So like I said earlier, ketamine's been used for years in surgery as an anesthetic, but that's in much higher doses than what we're using in the clinic for treatment of depression. And those doses are based on the patient's weight. Most of the studies that have been done have looked at using a starting dose of 0.5 milligrams per kilogram. So that's commonly where we start, but it's also then common for us to graduate the dose from one treatment to the next, and just gauging that based on how patients are tolerating it, but also trying to get the dose up to where we more commonly see antidepressant effects. The infusion itself is about 40 to 60 minutes, and then there's about 20 to 30 minutes of recovery time. And we usually see response within the first few treatments. I would say around treatment 3 or 4 is where we usually are really seeing that there's some improvement happening. Although some people are later responders, sometimes it's treatment 5 or 6. And in that case, sometimes we'll tack on a few more treatments to really see if we're seeing response. The treatments, the protocol that we follow, and this is a fairly common one across the country, is that we start with 6 treatments that we space out as 2 treatments a week for 3 weeks. And then beyond that, for people who have responded well to ketamine, there's usually a need to return periodically for some maintenance or booster treatments. And that varies for everyone. We have some patients that are able to go every 2 to 3 months in between treatments. We have some people who need to return every 2 weeks to maintain stability. I would say the most common interval for those maintenance treatments is monthly. And it doesn't apply to everyone. We have some patients who do the initial ketamine series and they do so well with it, they feel like they're able to then return to just working with medications, doing talk therapy, doing other things that help promote their mental health, and they don't need to continue to see us. There's no need to stop antidepressants or do any sort of a medication washout, although there are some cautions around the benzodiazepines, so things like clonazepam, Xanax, Ativan. In those cases, I'll usually look at someone's dosing, see if we might be able to reduce it. Lamictal, there's some controversy as to whether or not that may interfere with response. So we just try to be mindful of those things and tailor the treatment appropriately to each patient. Side effects during the infusion, like I mentioned before, brief increases in blood pressure, usually not a problem at all for people who don't have a history of high blood pressure. The increase in heart rate and blood pressure that you see is equivalent to even doing moderate exercise. So it's a little bit of a cardiac stress test, but generally well tolerated for people that don't have uncontrolled hypertension. And then nausea and vomiting being common. Again, or I may not have mentioned this, but it's very important. We instruct everyone no driving or returning to work the day of their treatment. So we want everyone to have a good night's sleep before returning to work or returning to driving. So everyone, people need a driver, whether that means they have a friend or a family member who drives them, We do have some people that utilize Uber if they're traveling to Billings to get these treatments from out of town. Couple of things that are really important for improving the quality of people's experience, and even a word on safety, is the concept of set and setting. So by set, I mean mindset. I encourage people to try to have a positive mindset coming in for their treatments. And by that, I mean things like, don't be on social media, don't be on the internet, scrolling through news headlines. Don't take a call from work or a family member you know is going to hijack where you're at with your emotions and with your thinking. Just try to carve out some space before the treatment to be in a positive mindset, and try to come into it feeling very open-minded, optimistic, hopeful, even curious. This is a really interesting treatment. So, and that's hard for people who chronically suffer from depression and anxiety and ruminating. That idea of trying to leave the worries of the world at the door is a little bit challenging, but it often makes for a much better treatment experience. And then the setting portion of that is what we try to provide for people. So in our clinic, we have treatment rooms where the lights are dimmed. We try to keep the noise and stimulation to a minimum level. We have some playlists through Spotify that we've curated to help enhance the ketamine treatment. We have some over-the-eye eye shades to help people block out external stimulation and really be able to focus more internally. And we have either RNs or paramedics who administer the treatments that are there for any support that the patients need. And with what I was saying with safety, what's so important about that is, like I said, ketamine is it's out there on the streets, in the clubs, available to use. So as people have heard, oh, ketamine can treat depression, I've heard people say, well, why shouldn't I just go buy it on the street and treat myself with ketamine? But you are not going to get the experience in terms of that set and setting and monitoring and safety that needs to be there in order to get the most out of this treatment and for it to be administered safely. And all of us who utilize this in our practices, we fear potential backlash with some of the things that are developing now, because there are some companies popping up that are doing at-home ketamine, where they do a very limited assessment. They send people ketamine to do in their home. There's no monitoring. It has the potential to be dangerous, and we would hate to see the possibility of losing this as a treatment option for people that are administering it very legitimately. It would really impact so many people. So some other pre and post-treatment precautions are no driving, trying to avoid stressful experiences afterwards and overstimulation, but just really allowing the brain to rest and respond to treatment. And I always encourage people to try to engage in some positive activities that do other things to support healthy mood and neurodevelopment. So things like spending time in nature, going for a walk, journaling. It can be good to write down any visuals or ideas or words that come up during the treatment, so that they're able to even process and integrate those things with their therapist. And spending time with supportive friends and family, which is always important. A word on the dissociative effects. So ketamine is classified as what's called a dissociative anesthetic. And with dissociation, that can range from things like feeling a floaty or a dreamlike sensation. Usually there's kind of a visual and auditory distortion where things may look different, sound different. It can feel like time passes very slowly or very rapidly. And those effects become more profound as we increase the dose. At the lower levels, people usually still have quite an awareness of being in the room, who's in the room, they're getting a treatment. As we graduate the dose, they feel more disconnection, which studies have pointed to the dissociation as possibly being a key component, at least for some people, as far as the therapeutic response, instead of viewing it as a bothersome side effect. That's kind of how it was looked at a few years ago. But for some people, the dissociation may be a key part with the therapeutic effect and with turning down that default mode network that I was talking about. And we really see very few negative experiences. Most people report that it's very pleasant, relaxing, interesting with what it brings up. The negative experiences I've seen are often where people have unresolved trauma. Sometimes it's very early childhood trauma that hasn't been unearthed or dealt with at all. That's where I've sometimes seen the treatment not go as well for people. But it can be a profound agent too, in terms of even bringing up some spiritual experiences. So it's just a very interesting agent with profound treatment effects. Another form of ketamine that's being used now is what's called Intranasal S Ketamine. So this is a derivative of ketamine. The IV ketamine is commonly referred to as racemic ketamine. So Intranasal S Ketamine, it's also marketed under the brand name of Spravato. It was FDA approved in 2019, and there are more strict parameters around the use of S-ketamine. It can only be used in patients that are over the age of 18, and it can only be used for 2 diagnostic indications. One is treatment-resistant major depression. With that, people usually have to, kind of like with TMS, they have to have failed a certain number of oral antidepressants first. Most insurance plans allow for the depressive episode to be classified as moderate or severe. And then the other indication is major depressive disorder with acute suicidal ideation. So what you don't see there with that diagnostic list is bipolar depression. This is not something that can be used in case of bipolar depression. Some other considerations, very similar medical precautions or contraindications that I mentioned with the racemic ketamine. And even though insurance coverage is available and a lot of plans are saying, yes, we cover this, it's a newer indication. So there are a lot of challenges to navigate on the insurance side. And we've been offering this treatment since March of last year, and we're getting comfortable with some of the plans, but some of the plans have been so challenging to work with that we just haven't been able to move forward yet with working with those particular companies. But the side effects are common. One thing that's different with Spravato versus IV is that we're limited to 2 dosing options. So with Spravato or S-ketamine, the doses are 56 milligrams and 84 milligrams, whereas with IV, we have a lot more flexibility with that range. And with Spravato, there's what's called a REMS requirement. So the drug company itself has a very strict monitoring program that goes along with that, and quite a bit of paperwork. So some of the requirements they have are similar to what we were already following with IV. So things like the treatments have to be administered in the office. This is not something that people take home. Vitals have to be monitored, and patients are required to be in the office for at least 120 minutes after getting the medicine for continued monitoring. And sometimes we get to a point, I mean, this happens very commonly, where it could be TMS or ketamine that could be appropriate for someone. And so we just look at factors like diagnosis, travel requirements. We treat people from all over Montana and Wyoming. We've even treated people from Canada. So we take into consideration things like travel demands, time and work commitments, financial and insurance considerations. But it is very common that sometimes we will start with one treatment and progress to the other if we don't see the level of response that we were hoping to see with just one. So I want to make quick mention of just some new horizons in psychiatric treatment. This is where I tell everyone, stay tuned, because it's getting very interesting. So with psychedelic medicine, there are over 25 academic centers with psychedelic medicine departments and studies at this time. But I want to emphasize again, just the importance that we need quality studies, safety, standards, and ethics. And I put a website here for your reference to see a statement about standard and ethics, at least in the ketamine world, and also just a good source of information and some facts and questions about ketamine. But much of what we're doing with ketamine is opening the door to the use of other psychedelic medicine. So those of us that have been practicing in the ketamine world are very passionate and committed to making sure that these medications are studied and that they're utilized properly. But some of the, there are studies out there that are happening with things, including ketamine, but also MDMA, psilocybin, plant medicines, psilocybin being one, but also ayahuasca, and then synthetic agents like DMT and LSD. And at this point, the science is really struggling to keep pace with public demand, access, and legal challenges and changes that are happening, because there are some areas like Denver and Oregon where psychedelics are being decriminalized. And so people have very wide access to them. And so the science, I feel, is just not getting there fast enough with giving us the parameters that we need in terms of safety and dosing and all of that. But I very commonly have people asking me now about the use of psilocybin and MDMA in particular. Some people have even researched clinical trials that are going on. So I think it's exciting that people are at least researching it and taking an interest. A few details about MDMA. So MDMA is also known as ecstasy or Molly. It seems to work by increasing the release of some of the neurotransmitters that we talked about in relationship to more commonly used antidepressants, but it also enhances the release of the hormone of hormones like oxytocin. And oxytocin is a hormone that we think of in terms of bonding and feelings of empathy. And MDMA was actually legally used within the field of psychiatry and mental health until it became a scheduled drug in the 80s. But it was used very commonly in marital therapy and in treatment of PTSD before it became scheduled. And let's see if I can go, just to comment on the picture you see here. This is how MDMA is being administered in the clinical trials. So what you see here is 2 sitters within the room, 2 therapists that sit with the patient. And it's a treatment that takes place over several hours. So again, this is not something that you would go out, get on the street, administer it to yourself, or take while you're in a club, and have anywhere close to the therapeutic benefit that can come from doing it with the proper set and setting and preparation. So MDMA is in phase 3 clinical trials for the treatment of PTSD. And there's a very strict setup with how that's being done, but I'm blown away at what we're already seeing from the phase 2 trials, which showed that 2 months after 2 or 3 sessions of MDMA assisted psychotherapy, 55% of people no longer met criteria for PTSD. That's astounding. Then when they followed those people up after a year, over 66% were still no longer meeting the criteria for PTSD with no other intervening treatment. So we need this treatment. I can't wait for it to get here. There's talk that maybe 2023 that we'll see it move from being a Schedule 1 drug, which means there's no medicinal benefit, to being Schedule 2 or 3. But again, under those parameters of it being combined with therapy and given in the office. And then a word on psilocybin, or also known as magic mushrooms. So again, lots of university departments that are looking at these agents, and one of them is Johns Hopkins. And the researchers have suggested reclassifying it from a Schedule 1 with no medicinal benefit to a Schedule 4 if it clears the bar of the phase 3 clinical trials. And they currently have active studies going on for treatment of major depression, anxiety treatment in cancer patients or people that are at end of life and dealing with some of the existential issues that come up with that, and also smoking cessation. And a very brief word about the role of integrative psychiatry. This is one thing I'm passionate is about, helping people find solutions beyond the prescription pad for feeling better. And part of what the graphic I put up here is this idea of the gut-brain connection, and how we often don't think of the gut-brain connection and a lot of other physically related factors that tie into brain health. But I think they are very valuable and worth including in our consideration of treatments that can help people feel better. And this is just a graphic that I made to show the many different slices of the treatment pie that I like to think of when I'm working with patients. So yes, we have psychiatric medications and we have ketamine, and in the future we'll have psychedelics and TMS, but things like exercise and movement and nutrition, looking at the role of food and how that affects our brain health and mood, gut support, hormones, the role of sleep, all these things are so important. So these are things I like to mention to people too when they are putting so much stock in getting better from TMS or ketamine and they're feeling like they're at the end of their options. I try to emphasize to people all the time to please be hopeful. Know that there's more coming, and there are so many other options for things that we can do to try to help you feel better. And with that, I invite you to seek out and do more information and research about ketamine, TMS, integrative psychiatry. I've put my addresses for my practice, Montana Psychiatry, where I do the ketamine and TMS. I've also put the address for Mood Restoration Institute, which I know is temporarily down. I just got notification that there's a problem with the website, but it will be back up. Stay tuned for, I'm hoping to develop some online courses this year, really addressing more of those topics of integrative psychiatry and ideas of things like nutrition and hormone balancing and things that can help with brain health. And then also I try to use my social media accounts to put the word out to people about these treatments and just other helpful tips for mental health. And I thank you so much for your time and your attention. Please, if you have access to the recording of this and you think that there is somebody out there that could benefit, a friend, a family member, a client, a patient, even if they're outside of Montana and they would never walk through the doors of my office, I want people to know different ways that they can find relief. So, thank you.
Thank you so much, Dr. Amato. That was amazing. We have a couple of really short questions.
Okay.
And I know we're past the hour, but one of them was, does Medicaid cover ketamine as well?
So we are now billing insurance for ketamine. They don't cover ketamine treatments per se, but we've been billing those more as just an in-office visit, and we've been getting paid so far. I hope it continues because it's been amazing for so many of our patients.
All right. And then we had a question, is there any advice about getting TMS approved without medical trials? This person is opposed to pharmaceuticals.
That would be very, very challenging. I don't think that you'd be successful with lobbying an insurance company, at least at this time. I'm hoping, again, in time, we may see more progress to where TMS may be considered first line at some point, but we're not there yet.
All right. And then we had a question about TMS for adolescents.
Mm-hmm. So at this point, it's still only FDA approved for people over the age of 18, although there are trials going on that show very good safety and very good response for adolescents. So most insurance plans will not cover patients under the age of 18. I think over the last 6 years of me doing this treatment, that we may have run across one plan that allowed for us to treat a 17-year-old, but otherwise it's considered off-label and usually not an option.
Excellent. And so we had a question about kind of ketamine being lumped with the other psychedelics and some of the cultural things for getting these narratives, you know, to get people to be more accepting and approving of them.
Mm-hmm. Yeah, when I'm talking to people about treatment options and I bring up ketamine, sometimes I hear, what, the horse tranquilizer? Or people associate it with negative things that they've heard. And I think by doing presentations like this and getting the word out and pointing people in the direction of reputable information, that it will help to dispel some of the fears that people may have or the negative perceptions of ketamine. And again, with psychedelics, I think the proof and the reassurance for people about that safety or removing some of the negative associations we have as a society about those agents, it's going to come from having reputable studies.
Okay. Excellent. Thank you. And I just have two more. This one is from the Senate Veterans Affairs Committee, and NAMI Montana has a bill in front of Congress right now to make TMS more available for veterans. So that's the GAPS Act. And so this one is, you mentioned that antidepressants don't need to be stopped while using IV ketamine.
Mm-hmm.
generally speaking, how are you able to differentiate the effects of these multiple treatments going on at the same time?
Yeah, and I tend to be very conservative about, I don't like doing multiple, I don't like starting or changing multiple things at once, but a lot of people come to me on a list of medications. They may be on an antidepressant, they're on something for sleep, they're on something that's augmenting the antidepressant. And because the people I'm seeing are so sick and needing relief, wanting relief, I don't want to take the time of taking months to do a responsible medication taper. So we usually just leave things in place. We don't change things. And then we add the ketamine in, and it's very clear to people if they're having a response. I mean, many people will say, you know, I'm responding to this more than I've ever noticed with any medication. And so with that, I like to see people at a point of improvement and stability with the ketamine before then very slowly initiating a medication taper. I don't like doing it too quickly. First of all, because I don't want to destabilize anyone, but also, and when people have been on medications for a long period of time, you usually need to really take your time with taking them off of those.
Excellent. The last one is about you know, some of the new treatments that are coming out, like FDA home TMS, which I think is probably more TCDS, if I get my acronyms right. But how do you think about kind of that people or companies beginning to look at home TMS and different categories for that?
Yeah, I mean, I think there's a lot of room in the field of neuromodulation or brain stimulation for even more technologies to emerge. And I kind of listed that on that slide about the future is now. There's look at ultrasound technologies and various things, but proceed with caution and really look at what kind of studies that they've done and the safety information associated with them. There's really not, I can't envision an at-home substitute for TMS. There are other at-home devices. There's the Fisher-Wallace device. There are some others that are a different type of brain stimulation, but it's not going to be equivalent to as powerful as TMS.
Yeah, it makes a lot of sense to me. So, Dr. Amato, thank you so much. This was exactly what I was hoping for. I'm sorry that I got cut off at the beginning. The way that you practice psychiatry and the innovation that you bring to this state is so amazing, and I'm really grateful for it. So everybody, please keep up with her on social media. I don't even have TikTok, but if you see her TikTok videos about being the psychiatrist and the patient, they're on Instagram. They're amazing. Just a way of talking about psychiatry that is so cool. So
thank you.
Thank you. And
yes, thanks so much. Thank you, Matt. And thank you everyone for tuning in.
All right. Thanks everyone. Have a great rest of your week.